Hi, and welcome to another edition of the IBD Roundtable discussion. My name is Frank Garufi, your host and founder of the Crohn's Colitis Effect, and I'm here tonight. I can't wait for us to get started tonight because we just have an episode that I've been dying to do for a long time, and I just know is going to be a great show. Let's start off tonight with a couple of things. First, I'm going to ask for Marisa to introduce herself.
Hi, I'm Marisa Troy. I write the blog Journaling IBD. I'm really excited to be here with Dr. Higgins and Sara, Ryan, and Frank. I was diagnosed with ulcerative colitis at the age of 13. I'm 28 now. I've since lived with a G pouch, multiple cock pouches, and now live with a permanent ostomy.
Thanks. Ryan?
I am Ryan Stevens, and I occasionally blog over at crohnsguy.com. I haven't written anything for a while, but very honored to be here, and can't wait to talk to Dr. Higgins, and it's going to be a great night.
Great. And I want to, Sara, I'm going to ask you to introduce yourself, but before I do, I just want to say congratulations on your your WeGo Health HA Awards, both Lifetime Achievement and Hilarious Activist, and it's very well deserved.
Oh, well, thank you very much. Now I feel like there's expectations on me to be funny, and I don't know how I got that award, but that's cool. But I'm Sara, as it says below, and I am the person behind Inflamed and Untamed. I have been living with Crohn's disease since I was a child and have a J pouch now. And I am most well known for my YouTube channel where I talk about my experience with IBD, where patients can relate to me and feel like they have somebody that they can connect with and get it. And I also like to do my best at educating patients and others about inflammatory bowel disease.
Thank you so much. And our special guest tonight, Dr. Peter Higgins. Thank you so much, Doctor, for being on the show, and if you wouldn't mind introducing yourself.
Sure. I am the director of the IBD program at the University of Michigan. We are on YouTube at IBD School, some educational videos for patients, on Facebook at University of Michigan IBD Team, and Twitter at IBD Doctor. And we've found that it's really important for our patients to get really well-vetted information so that they can make informed decisions about their own care.
That's great, and we really appreciate having you on tonight. Before we get started with the questions from everybody, I wanted to say not only did I want to, I'm very happy that Sara Ringer won her awards. I just want to give a quick shout out to Vegan Ostomy, who also won an award yesterday for Best Kept Secret, and for Meg Johnson for the Front Butt YouTuber for her Best in Show YouTube. So the IBD community was very well represented at the WeGo Awards, and I just couldn't, I don't think that there's a better group of people advocating right now, and I'm just thankful that they work so hard to bring so much awareness and so much education to everybody in the community. If you haven't checked out all of their stuff, go to WeGo Health, see their links that are on there to their sites, and check them out. I also want to thank both Marisa for helping me produce tonight's show, and also Allison Rotham Banks, that's in our chat. She's our chat moderator, and she helps us out. Speaking about the chat, if you're not watching on our website, which is on the lower third below, go to our website, cceffect.org /watch-live, and you can jump into the chat, ask us questions, and talk to us while we're doing the show. And with that, we'll get the show started. Marisa, I believe you have the first question for Dr. Higgins.
Do you find that there's any way to tell beforehand if a J pouch will be successful in an ulcerative colitis patient? Like, I know there's no, one size fits all and everything, but have there been any studies or patterns that have been noticed?
So the biggest and most important one, which isn't really completely ahead of time, is whether there's a leak in the J pouch. If the J pouch connection has a leak, that usually creates an abscess, so a lot of scarring, and makes it very difficult for the J-pouch to stretch, and in the long run makes the J-pouch function a lot less well. And a lot of those folks, unfortunately, have to have redo pouches or terminal ileostomies. In terms of predicting truly before the case, probably our best predictor is trying to predict whether somebody actually has Crohn's rather than UC. The strongest predictor is a family history of Crohn's disease, a first-degree relative with Crohn's. There are some antibodies, the ASCA antibody, that's somewhat helpful, but by far the most strongly predictive is whether you have a first-degree relative with Crohn's.
So that's what you look at before you operate on an ulcerative colitis patient, just kind of rule things out.
And look for anything else that might be suggestive of Crohn's. If there's any evidence of small bowel disease on a scope or a scan, if the ulcers in the colon are especially deep or long and what we call serpiginous or snake-like, that's more typical of Crohn's than for UC. And we look for things that might hint that, but a lot of times it's a decision on the spot. Does the patient really want to give it a shot?
Right. Okay.
Is there any statistics, Doc, that show how many patients have been diagnosed originally with UC, as in like the case of Sara Ringer, where she was diagnosed originally with UC and then later found out that it was a misdiagnosis and it really had Crohn's disease?
Our numbers in terms of people who get operated on for UC eventually declaring themselves as Crohn's is about 5%. And I have to say, it may not have been truly a misdiagnosis, that a lot of times, even if you go back to the colon in the lab and look for any evidence of Crohn's, sometimes you just can't find it. And it may be that people truly transition from UC to Crohn's. Because we've looked, I mean, I've had patients we've hunted high and low for any evidence for Crohn's beforehand and just not been able to find it.
Interesting.
Is there a typical, I mean, is it kind of like after you have your colon removed, if you don't show symptoms of Crohn's or another, I guess, type of inflammatory bowel disease, then that's pretty much the diagnosis? Or could that change in like 20 years? Could you go from being a UC patient to Crohn's?
Most of the time, if you're going to see it, probably 80 to 90% it's going to be in the first 5 years after the colectomy.
Okay. Makes sense.
So it's unusual to be, say, 20 years out and suddenly it's like, wow, it's Crohn's. Usually it's in the first 5 years.
Okay. Thank you.
Okay. Ryan, you had a question?
Yeah, I am curious about biologic medications like Remicade, how the mechanisms that make them work, how they work, and why would a patient grow immune to them?
So there are two main families of biologic medications right now, anti-TNF medications and the anti-adhesion medicines. First one of those is vedolizumab. There are other categories that are still in development in clinical research right now that will probably be on the market in the next 5 years. But the unifying factor is that these are foreign proteins that are not natural in the body. They're monoclonal antibodies. Eventually, the body is prone to recognize these as foreign proteins and make an immune reaction to them. And that may be just clearing the drug quicker, getting rid of it in the spleen, or actually making neutralizing antibodies against the biologic medication. Now, this is true in anybody taking a biologic, but it's probably especially true in people with autoimmune disease. Because their immune systems are more activated, they're more likely to make antibodies or make immune clearance mechanisms to these foreign proteins than, say, somebody taking a monoclonal for some other diagnosis, not an autoimmune disease.
Doc, my son gets Remicade every 5 weeks, and we normally do a Remicade level each time that he goes in. Some months it comes back at, say, a level of 3. The next month or the next 5 weeks, it might come back at a level of 7. Is there a reason why in one set would be, 3, and then another set would be 7?
Some of it may simply be lab error. There is a lot of variation, and these assays have not been standardized. So if you send the same assay to 2 different companies, same tube of blood, you'll get 2 different numbers.
Ah, okay.
So there's a problem right there. The other issue is that you get a variety of things that affect the clearance, including how much ulceration you have in the intestine. So it can literally leak into the stool. Or if you have a lot of TNF, a lot of it can be soaked up and be bound in the intestine, but not be present in the circulation. So it can vary bit to bit. Right now, there's not a ton of data on the value of doing regular levels in somebody who's doing well. There was a study last year in Belgium, the Taxit study, where they randomized people to monitor their Remicade with levels every single infusion or with CRP every single infusion, and really didn't see much difference. So at Michigan, we tend to use CRP at every infusion and look for that. A rising CRP as a signal that something may be going wrong, and then check a level. Partly because levels are pretty darn expensive and CRPs are cheap.
One of the things, the reason why we've been doing so many Remicade levels is because we're trying to, we tried to move them out to 6 weeks from 4 weeks, and it started to become a little bit of a problem, so we moved it back to 5 weeks, and then we're just trying to see if the Remicade levels are holding and that he can sustain 5 weeks going forward. So
yeah, so in terms of maintaining good drug levels and long-term remission, first, we don't know quite what the right level is. There was a paper that came out at ECHO last month that suggested if your goal was a normal CRP, you needed at least a 3. If your goal was having normal-looking intestine through a scope, it should be at least 4. And if you wanted a totally normal fecal calprotectin, you needed at least 5. So you sort of pick what your sensitive endpoint is. The other thing worth thinking about in anybody who's concerned about biologics and drug levels and losing effect is that taking a co-therapy with an immune modulator can increase the levels of drug and reduce the clearance of drug. And there are several to choose from, things like azathioprine and 6-MP, methotrexate, and sometimes we even use Cellcept.
Okay. Sara?
Yeah. So this is not a question that I actually had myself because I know the answer to this, but I thought that we could kind of address some misconceptions that the community has about IBD, and one of them is that you can have both Crohn's disease and ulcerative colitis. So I was wondering if you can explain to patients how that isn't possible, and I'm going to talk about how there's actually many types in my next question to you, so I don't want to get that far, but could you just explain that you cannot have both?
In general, we give somebody one diagnosis, and we try to pin down, in general, either Crohn's disease or ulcerative colitis, and where a lot of confusion comes from 2 other conditions that are related. Crohn's colitis, or Crohn's disease of only the colon, which happens in about 1/3 of people with Crohn's disease, and indeterminate colitis, which is basically people with colitis that it's not entirely clear if it's ulcerative colitis or it's Crohn's disease because it's sort of in between. And that may be a real phenomenon that some people are truly in between.
Cool.
Great. Doc, I wanted to kind of talk a little bit for a second about the relationship between patients and GI doctors. What is, in one of the other chats that I've done with you, we talked about what the patient can do to build a better relationship with the GI. But, one thing that we didn't talk about during that chat is what is the biggest hurdle that you face when you develop a new relationship with a patient? Are there things that the patient can do to kind of help you to do your job better and to form a better relationship so that way you're working as a team rather than going in separate directions?
Sometimes the hardest patients to really connect with are the ones who are just overwhelmed, and they have a hard time putting their story together and really explaining what is their goal in the short term. A lot of times they may have a list of 10 or 15 goals, which is very reasonable, but it really helps if they organize it and say, for today, I really want to figure out how the heck I can get off steroids and still have control of my symptoms. And at our next visit, can we talk about how am I going to get back to college? How am I going to get better control of this urgency? And have priorities and make lists. And just, it's hard because a lot of times people get to the doc and just vent and dump everything out, which is totally understandable. But if you can kind of prepare for your visit and organize your key questions, what do you really want to get answered this time? And try to focus, of all the things on your list, organize them and say, there are some things we may get to the next visit, which is fine, but these are the things I really want to focus on today. And so prepare mentally for what do you want to get out of this visit. That can help a lot.
Great. Good to know. Marisa?
As a doctor, how do you balance not wanting to get emotionally involved with your patients, but also wanting to come off, warm and understanding? Have you found this to be a difficult part of practicing medicine?
It can be, and you definitely have to have borders. You have to reserve time for yourself, for your family, so you can go back on Monday refreshed and ready to go. I've certainly seen a lot of people just not have any barriers and get kind of burned out. And it's important to just say, when I'm here, I'm on. I'm in clinic and I'm here 100%. And there are going to be times when you have to be able to step away and say, this is family time or my time.
Right. Is there a way that, I know in some ways you kind of have to be a little bit emotionally involved in order to come across as caring and to allow the patient and caregiver to know that you understand their unique situation. I just, for me personally, I don't know how I'd be able to take care of patients, and obviously everybody's story is, so heartbreaking. I don't know how I would really be able to do it without getting emotionally involved. So I'm always curious how some doctors are able to do it, and it doesn't seem like others can.
I think it's to be emotionally involved, but be able to put it away when you go home.
Yeah.
There has to be a point where you're there for your family and your friends.
Yeah. No, absolutely. Absolutely.
Brian?
So before my second question, I just want to say, Dr. Higgins, I greatly appreciate that you do take the time to be on Twitter and Facebook and putting out accurate information, and you're very available for people. So I greatly appreciate that.
I'll second that.
Me too.
My second question is building off my first about biologics. Are there any new medications on the horizon that you know of that are coming out for treatment of IBD?
So the ones that are getting closest in terms of biologics, probably the closest is ustekinumab, also known as Stelara, which is on the market for psoriasis. Very, very effective for psoriasis. And in a phase 2B study in Crohn's was also very effective. The phase 3 study, we participated in Michigan. It's complete. They're also doing a phase 3B in patients who are TNF naive, which unfortunately is kind of slowing it down because a lot of the patients who are TNF naive don't necessarily want to take a biologic, so it's harder to recruit.
What does that mean, TNF naive?
So a patient who has never been exposed to things like Remicade or Humira or Symphony or Cimzia, and so they've never taken a TNF biologic before. And unfortunately, those are the patients who may not want to take a TNF at all. And I think the company's idea is they want to get it approved as potentially a first-line therapy, which is understandable, but it's also delaying it getting to market for patients who failed anti-TNFs and need a drug now. So that one is very impressive. It's solid. It's particularly good for people who also have skin issues because it's good for psoriasis. So people who have eczema or erythema nodosum are great.
Stelara is same maker as Remicade, right?
Yes. Yes, and that is a subcutaneous injection. So you inject it yourself under the skin, either every 8 weeks or every 4 weeks. And it looks pretty promising. The other two that are on the way in the category with vedolizumab or Entyvio, these are gut-specific monoclonals. Both of them have the same idea that they're gut-specific, a lot less risk of infection or cancer. One of them is etrolizumab, which is a subcutaneous injection. You can do the injection yourself. That looks pretty promising. It's in phase 2. And the third one has a horrible name, and it starts with PF and has a number, but it actually binds the opposite molecule, the one on the blood vessel in the gut, and prevents inflammation that way. We've had patients in both of those studies who've done very well.
We'll just call it PF Chang's.
Yeah, that's a good one. I like that.
Could I
starts with PF.
Could I interject with just a question from Twitter to go along with that?
Sure.
I have UC and I'm faced with Humira or Symphony. Is one better than the other? I know there's obviously, no way to really tell, but do you have an opinion on what's more effective in an ulcerative colitis patient?
So in ulcerative colitis, if you look at the results from the trials, admittedly against placebo, they look almost exactly equal. They're very similar. I think, bottom line, in turn trying to choose, you might look at, what is your insurance company going to let you get, what the copay is going to be, or if that's not an issue, Humira is every 2 weeks and Symphony is a little bit more. And so maybe if you are a little bit more afraid of needles, you might go with the Symphony.
Okay, great. Thank you.
So not too different. And at this point, it looked like for some reason for ulcerative colitis, the IV medications seem to be more effective. I'm not sure why. But just looking at the raw numbers, admittedly no head-to-head yet, the raw numbers suggest that Remicade and Entyvio may be better than the subcutaneous injections. Hopefully there are going to be some head-to-head trials. I know the folks who make Entyvio are going to try to go head-to-head with one of the subcutaneous meds. So pretty soon, probably in the next year or two, we'll start seeing head-to-head to see which one's really better. I know we're signed up for the Entyvio versus Humira study. That'll probably start in about 2 months.
So I had to divert my attention a little bit, but did you just talk about all about the about in Europe how Remicade and I believe there's one other biologic that is now going, I guess you can say generic or biosimilar?
Right. So that is a new area that in Europe, and this is very different from the FDA, they basically said, prove that it's chemically similar, and we'll put it on the market. So they have biosimilars in many countries in Europe. The first one is comparable to Remicade, and I think it's called Remsima, so similar to Remicade. It's about 60 to 70% of the price of Remicade. The makers of Remicade have lowered the price in Europe to be competitive, and it's lowered the price for everybody there. And so far, the word out of Europe is it seems to work about as well. As best I can tell, the FDA is going to request some clinical trials in humans and show that it's truly equivalent clinically, which the Europeans didn't require. So there are going to be studies. We're actually running one at Michigan where people get randomized to either original Remicade or the biosimilar and see if there's any difference. So that one, people could enroll tomorrow and get free Remicade or the biosimilar. The benefit to everybody is figuring out, do we have a generic or biosimilar equivalent that would be a lot cheaper?
I'm guessing that we would have the same standards as far as the equivalency as that of right now if you went and to your pharmacy and got a generic rather than the name brand pill.
So actually for biosimilars, so just let me step back. That's the way Europe treats it. If it's chemically similar, they're good to go, which is all we do with generics. In the U.S., the FDA is saying that's not good enough. These molecules are so complicated, we want to see you prove that in patients it's truly clinically equivalent. So the bar is a lot higher in the U.S.
Okay. Sara?
Well, I had my questions on my lap and a cat sat down on top of it, but I'm going to see if I can remember what that was. And I think I'm going to skip to my third question and then go back to my second. But I wanted to sort of just ask so everybody else could hear that everybody's IBD is kind of unique in its own way, that no two patients are similar. So like my Crohn's disease would be different than Ryan's and so on. And I was hoping that you could explain that a little bit and why we need so many different kinds of treatments because of that.
Right. So what we call Crohn's disease is a group of conditions that people have that look similar. What we call ulcerative colitis is what looks similar and look the same. But we now know, based on the CCFA genetic studies over the past 10 years, that there are about 170 different genes that are involved in Crohn's disease and ulcerative colitis, and about 70% of them actually overlap between the two. So there are going to be people who are very UC-like, who have a disease that's very Crohn's-like, but most people are going to be somewhere in a spectrum in between. And if you think about all these different genes, At each locus or spot on a chromosome where one of these genes is located, you have a copy from your mother and a copy from your father. That's two possibilities and more combinations. When you think of all the combinations of 170 different genes, you can actually have millions of different combinations. It's 2 to the 170th power. So that each person truly genetically, in terms of the risk factors, is unique. You could argue that some of them can be lumped together, and they can, because treatments like Remicade can work for 60 to 70% of patients. But it's not surprising, given how diverse the diseases are, that for a fair number of people, any one treatment isn't going to work. And we may eventually have to have really unique treatments or targeted treatments to groups of people with Crohn's or groups of people with UC or this indeterminate colitis. And I think of it a lot like when President Nixon back in 1973 said, we're going to fund the NIH for a war on cancer, and we're going to beat cancer in 10 years. And that was based on the idea that cancer was all one thing. We have much better understanding that there are a variety of different types of cancer genetically, as well as where it starts in an organ. And once we figured that out in particular cancers, we've been incredibly successful. For a lot of cancers, we haven't gotten there yet. But the more we understand a particular type of cancer, the more successful we can be. I think that's where we're eventually going to get with Crohn's, is we're going to be able to type Crohn's and UC very specifically and hopefully get to the point that we can say, for your type, this is the best therapy. Or here are 2 or 3 choices of therapy that will work better than others.
Cool.
Adam in our chat just asks, where can I find what genes I'm dealing with? Is there a way for patients to know what genes are affected for them with their IBD?
There are a few that are easy to genotype. Most of them require, they're really research tools at this point. And part of it is that most of the genes individually contribute very little risk. And at this point, we don't know for any given set of mutations how to best treat somebody. So at this point, it's still a research tool, and we're gathering data. We wouldn't know what to do with an individual's data if we had it, unfortunately, at this point. So right now, I would say if you're really interested in it, join in one of the large data bank or biobank studies, and probably the biggest one was actually recently funded through the CCFA by the Helmsley Foundation. They gave them $17 million to try to investigate things like the genetic connection to what therapies work best. So that's coming soon, and I would encourage anybody who's interested in that area to definitely participate.
Great. Doc, I know dehydration and chronic dehydration can be a huge issue for IBD patients. How can patients tell if they're dealing with this issue, and what are some of the ways it can be dealt with? When drinking plenty of fluids and using, products like Drip Drop for hydration aren't enough, what are some other ways that the issue can be addressed?
So probably the most striking thing I learned with that was a few years ago when there was a clinical trial of what was called leukapheresis, the idea that you could filter out the bad white cells. And the interesting part about that is they did a regular arm where blood came out of the patient through a filter and back in, locked in a black box so nobody knew which one they were on. Or it could loop around the filter and never go through the filter and come out. But to make it work, they had to prime the system with 2 liters of IV fluid every time. So the patient got a net positive 2 liters of fluid on Monday, Wednesday, and Friday. And the amazing thing is that if you look at how the patients felt and quality of life, they got much better in both arms, whether they had the filtration or not, because they were getting an extra 6 liters a week. And so I think what we know, most of what we know about hydration comes from treating people with dysentery and really horrible diarrhea that's infectious, where people have done large studies. So adding salt to the fluids, adding sugar to the fluids increase the rate of absorption, because for every molecule of salt or sugar, more water gets absorbed. The other thing that's been shown recently is rice water, that one of the components of rice is actually helpful. And so a lot of times, especially in India and Bangladesh, when they have infectious diarrhea, they'll use rice, water soaked in rice as the basis of their rehydration solution. Most people don't want to go to the effort, and it's easier to buy a commercial product like Drip Drop or Pedialyte or something like that that's been formulated with salt and sugar in the right balance with the fluid. The key thing is to get enough, which is hard to do, and to keep up with your output, which is hard. And I think the key thing is to monitor things like how much urine are you making, what color is your urine, because your kidneys always know if you're dehydrated. Even if you feel okay, if you're not making a lot of clear urine, you're probably behind. And when patients end up in the hospital, what I teach interns is that most IBD patients come in the hospital about 10 liters of fluid behind. And they really need to give you about 10 liters IV to catch somebody up when they're really sick before you really get that clear urine flow. And the striking thing about that is a lot of times somebody will come in, they might come in with a CRP of 6. If you give them a bunch of fluid and actually flush out and increase the blood flow to their intestines, more of the inflammation and cytokines will go from the intestine to the liver where the CRP is made. And a lot of times on the second day, their CRP will actually go up because we're flushing out their intestines.
So I heard you say once before that when you explained getting hydration, say Monday, Wednesday, and Friday, is that something that is unique to you in your practice, or is that something that is widely accepted for IBD patients when dehydration is an issue, or is this something new that's coming about that they're starting to do?
It's been something that's been around, and it's sort of been considered a little bit of a desperation move, and it's a pain in the neck for the patients, or a pain in the antecubital vein. Patients are coming and getting poked 3 times a week. It's a big deal and very inconvenient. And the idea is, ideally, it's a bridge to get somewhere where you can come up with a therapy that will keep people hydrated, and you won't need that. Now, some of our patients with short gut, that's just not going to be possible. And we have some patients on long-term TPN plus or minus fluids. And sometimes that's just where you are if you're under 100 centimeters of small intestine.
Okay. Marisa?
How have the changes in the healthcare system impacted your ability to practice medicine, or have they? I guess they should ask. Like, for example, do you find that you're using more patient portals to communicate with people as opposed to either speaking on the phone or inpatient visits?
Absolutely. Patient portals have won the day in the last 2 years. Mm-hmm. So we really do a lot more with patient portals. And to be honest, you can only talk to one person at a time on the telephone. It's pretty slow and inefficient, whereas the portals can be a lot faster. If you're going in depth, there's a time and a place where a good phone call will go a long way. The other big changes, the biggest one for IBD is probably the establishment that you can continue on your parents' health care until your 26th birthday. That was huge for a lot of my patients.
It was huge for me, too, yeah.
The elimination of pre-existing conditions as a reason to not insure somebody was absolutely enormous for my patients. We're seeing in the past year or two with the health exchanges a lot of people who basically couldn't get health insurance and were living on prednisone kind of coming in from the cold and just saying, wow, okay, you haven't had real treatment in 2 or 3 years or 10 years. What can we do now? So really big changes that have made a big difference. Absolutely.
And do you think that they're all positive, or do you see any negatives to communication?
Mostly positive. I think there are going to be challenges. I think right now insurers are a little bit in shock at the cost of biologics. Mm-hmm. They're not quite sure how to cope with it. A lot of times it's just a blanket denial. We're going to deny all biologics and see how bad the doctor really wants it. And you have to write letters and make phone calls, and the patient has to make 17 phone calls, and it's very painful. I wish there were a more logical way to decide when people need biologics, and we wouldn't have to fight tooth and nail for this. Mm-hmm. Or at least if they could say, okay, we're not going to cover A, but we'll cover B, rather than us trying to guess what's covered on a given day.
Right.
We spend a lot of time doing that, unfortunately.
Yeah, sure.
On the other hand, our system has some benefits. I was at UEGW last year when they did a presentation on the use of Remicade for inpatients with severe ulcerative colitis, and 80% received 4 doses or less, and then they just stop because they just can't afford more than that. That's usually not an issue here.
Yeah.
And if I'm correct, isn't that an issue where once you start something like Remicade, and then you come off of it, your body starts to build antibodies against it?
So there are 2 pieces that. One, if you're going to stop, it's really important to stop cold turkey and not sort of stretch it out and dose intermittently. It's the dosing intermittently that's more like vaccinating. And the second piece is if you stop while you're on an immunomodulator like Imuran or azathioprine, you're likely to forming antibodies is much lower. So if you're going to stop, it's much better to already be on something like Imuran for 12 weeks and make a conscious decision to stop with the Imuran in place to protect you. A couple of studies in Europe have shown if you do that and you restart Remicade later, you have a 90% chance of success.
Interesting.
Yeah, it is.
Ryan, your next question?
Okay. My question, in your opinion, is the USA, the United States, doing enough to ensure that we have up-and-coming IBD doctors and surgeons? I ask this mainly because I've had many friends who have, in my opinion, been butchered by surgeons and been given very inadequate care by GIs.
I think there are a couple of issues, and it's interesting to contrast what happens in the U.S. to what happens in the UK. So the UK, about 5 to 10 years ago, decided that we really need to improve the quality of care for IBD in the entire nation. How are we going to do it? And got to there and really thought about what the best way to do that was, and decided that the best way to do that was to have expert IBD centers and have strict criteria of if a patient is not doing well in their local doc's office, to send them to an IBD center and improve access to IBD centers, have more experts in those centers, and not try to spread out the expertise. That's had really pretty remarkable effects on the overall average quality of care in the UK. In the US, on a lot of levels, we've been really reluctant to endorse the idea of IBD centers. We have fantastic IBD centers, but the whole market economics of healthcare in the U.S. means that every doc is trying to get the most patients possible, is trying to keep the most patients possible, and not send those patients away. So unlike the UK, where there's no incentive to keep patients, if the patient needs to go, they send them. In the U.S., there's a lot of incentive not to tell patients, hey, you know, there's a great IBD center at Mayo or Chicago or Ann Arbor or Cincinnati, when that would be a really helpful thing. It's a tough situation because even the CCFA politically is really reluctant to tick off anybody and say, hey, there are IBD centers that offer really tremendous care. Why don't you get a second opinion? Which is interesting because in the U.S., for children, for cystic fibrosis, it's absolutely different. Everybody recognizes that there are cystic fibrosis centers. There is a network of them. Everybody says, oh, absolutely, you have cystic fibrosis, you go to a center. So it's kind of a funny thing. I think a lot of patients don't have insurance, and that's a huge barrier. But even patients with insurance don't necessarily know that, hey, it's at least worth getting a second opinion at an IBD center just to make sure I'm getting everything done right.
I mean, that's a great question, and you know, just to talk a little bit about my son and what we went through prior to bringing him to what I would consider to be an IBD center at the Children's Hospital of Philadelphia.
Absolutely.
I went through close to a dozen different doctors and specialists before getting him to CHOP and really getting a handle on not only what was wrong with him, but how to start treating him for this. And it was beyond discouraging for me, Doc. I mean, it was to the point where some doctors were even saying that I was personally trying to harm him in some way, and I was neglecting him, and that's why he was having these problems. So, yeah, there are unfortunately some real bad doctors out there. and people who are not taking care of patients the way they need to be, especially when I kind of feel like they don't have an answer for what is obviously right in front of them, something that's wrong. You know, can you just kind of talk for a second about why do you think maybe some doctors, and I'm asking you to speculate here because you can't speak for other doctors, but why is it difficult sometimes for doctors to just say, I don't know?
That's, you know, I think a lot of people are uncomfortable saying that from the get-go. A lot depends on where and how you were trained. That was a big thing where I trained at Duke, to be able to say I don't know and get some help. But, you know, I think the financial incentives are big. I think it's the reality. You know, folks used to make lots more money, and funding and insurance reimbursement have been cut, and I think it's hard for folks to say, look, I'm going to take the financial hit and send you somewhere else. So I think they mean well, but it's hard to do. It's hard to admit that this isn't your area. But to be honest, most GI docs don't see IBD all the time. IBD might be 5 to 10% of their practice. And there's so many changes, and it's changing so fast with the new meds. And a lot of these meds have some risks, and they need to be very carefully used. And I think there's some real benefit to going to an IBD center. I think in some ways it was a lot easier to do in the UK because geographically it's a lot smaller. It's not like somebody in North Dakota has to drive 12 hours to get to the Mayo Clinic, or somebody in the Upper Peninsula of Michigan who has to drive 13 hours and stay overnight and see me and say, hey, you know, I got to have an appointment at 7:30 because I got to start driving back. Yeah. We see it all the time.
Yeah. Sara, your question?
Yeah. Can I just follow up on that? Really not even follow up on that. I just want to say that it's all interesting. I wish that we had IBD centers and better care like 20 years ago when I was growing up, because it's just so different these days. But,
and a lot of it is the research and a lot of new meds. And, you know, it's interesting. The biologics have been really beneficial for a lot of people, but they may be just a phase in how we get better at treating IBD. Because at this point, the biologics still have a huge Achilles heel that you develop antibodies to them and they eventually stop working. I think the longest I've had a patient on biologics is 12 years. If you think about the typical patient at age 17, 18, or even age 7, one biologic isn't going to get you very far. So I'm really excited about some of the new oral medications that are in the pipeline. Tofacitinib, which is a JAK inhibitor, has done really well for UC and is in trial for Crohn's, and there are at least 2 other JAK inhibitors in the pipeline behind that one. There is a new sphingosine receptor modulator, Ozanimod, that's been really successful in phase 2, and another one with a strange name called Mongersen that has looked promising in phase 2 and was actually had a paper in the New England Journal this week. And the nice thing about those is they're small molecules. You make antibodies against them, and someday when the patents run out, they'll make generics and they'll be a lot cheaper.
Great. Yeah, so my second question was kind of answered already, but I figured we could talk a little bit. We were talking about this before we went on air, but the biggest hype this week is that you are 3 times more likely to get Crohn's disease if you have taken birth control. I just thought we could talk about that a little bit. What do you think about that, if it's true?
So any epidemiologic study you have to take with a huge grain of salt and think about how they studied and what they showed. So what they showed was what we call an association, that one thing is associated with another, not that one causes another. And a lot of times you think about that, and sometimes the cause can go in the other direction, that people with IBD may be more likely to take birth control because they're sick and they don't want to have children when they're sick. Or that people who get birth control are people who obviously have insurance, went to a doctor, and filled a prescription, which is probably more true of people with IBD than people without. So there are a lot of possibilities that might explain an association like that in sort of a silly way. And you have to step back and say, okay, is this realistic? does this make sense in terms of a mechanism? Well, if that were true, and you think about the number of young women in the U.S. who take birth control, you would think there would be a lot more young women than young men with IBD, and that just isn't happening. So it makes me skeptical that this is a real causative association. It may just be by chance, or it may be through some other association that birth control is associated with insurance and having insurance is associated with IBD. So I wouldn't put a lot of weight on it. I think IBD patients should think a little bit about hormonal birth control because it does increase your risk of blood clots, which are pretty common in IBD patients who have active disease or are on steroids. So you might think about, say, for example, using an IUD instead of hormonal birth control. I think it's a pretty reasonable thing considering the risk of clots. But I wouldn't say, wow, I'm not going to take birth control because of this, because it's just an association. It doesn't make a lot of mechanistic sense, and it may not be real.
And for girls who already have IBD, it would just be a silly thing to stop taking birth control to think that they would feel better, as if their birth control was making them feel bad.
Yeah, it's pretty unlikely.
Yeah.
And you have to think about, there was a pretty famous Birth Control Association paper about 25 years ago where someone showed that being on birth control was associated with having HPV, which, and the people started thinking, wow, birth control is causing HPV or making people susceptible to HPV, when if you stop and think about it, people who use birth control probably have more sex and probably have more partners. And people who have more partners are more likely to get HPV. And it's not a causative effect, they just happen to both be associated.
Right. Cool. Thanks.
Doc, I'm gonna I've got another question for you, and then I'm gonna start taking a lot of the questions from the chat and asking you them. I'm also going to ask the panelists to just jump in with questions or comments that they have with some of these as well. One of the questions I wanted to ask real fast, though, it comes from UC Problems in our chat. I read that the PO mesalamine, which I also believe is called Pentasa as well, medications are no longer recommended. Do you still prescribe them to your patients?
So oral mesalamine products, and there are a bunch of them, Pentasa, Lialda, Delzacol, are FDA approved and clearly work for ulcerative colitis. They are not FDA approved and clearly don't work for Crohn's disease. So I don't prescribe those for Crohn's. Occasionally I'll meet a patient with Crohn's colitis who do get some benefit. And there is one meta-analysis that suggests that for people with Crohn's colitis, about 9% will get benefit from mesalamine. Now, considering these run $300 to $400 a month, if only 9% of people are going to benefit, it seems like a low-yield strategy. So if I meet someone who's already doing well, I'm not going to take them off it, but I'm certainly not going to start anybody on a 5-ASA medication or mesalamine medication for Crohn's disease.
Okay. Another question from our chat comes from Kelsey Linfoot. Wondering what the monitoring protocol should be for IBD. For example, how often and what sort of blood tests should be run or other testing? There's always talk about monitoring and administering medications, but little on what protocols are usually recommended for monitoring inflammation.
So that's still a little bit of a moving target. We have a lot of data in just the last few years from research studies. We now know that in most patients, some evidence of inflammation will show up long before symptoms occur. And typically we measure things like CRP or fecal calprotectin. And generally those will start to rise about 12 weeks before you have any symptoms. So in a patient that for some reason we're suspicious has tenuous control or maybe lowered their dose of medication or stopped the medication, we'll often check inflammatory markers every 12 weeks just to make sure they're going to do okay.
Great.
Other things we look at, anemia is important as a marker that people aren't doing well. Iron deficiency often is a marker because when people have active inflammation, they don't absorb oral iron, so that's often a sign that things are going badly. If the albumin is low, that's a marker that their intestines are leaking protein. And often that indicates that there's long-term ulceration. So there are a lot of things we watch, but in general, we're looking for, is there inflammation right now, and can we detect inflammation before a patient has symptoms?
Okay. From Allison, our moderator in the chat, can you give us your thoughts on the 23andMe study?
I have to say I'm a little puzzled by the 23andMe study because the NIH funded through the CCFA a massive genetic study on IBD. It's already been done. So to be honest, I'm not sure what the goal of the 23andMe study is other than getting patients to donate their genetic material. It's not clear that they're adding anything, and it's a little challenging because unlike the NIH study where every patient was carefully examined by a doctor and phenotyped and figured out if they had Crohn's or UC or Crohn's colitis or indeterminate colitis, 23andMe is basically taking people's word for it, and that's fine, except that a lot of people don't know, and some people think they have both Crohn's and ulcerative colitis. So I would think their data is going to be pretty messy, and will probably be a lot less useful than the NIH study that's already been done.
Okay. Sara, actually, you had another question that we had that is kind of important because of another question that I have. I don't. It's kind of a follow-up to this, but do you remember the 100 types?
Yeah, hang on. The cat is moving off of my questions now.
Okay.
Yeah, it was just, and you kind of answered it a little bit in my third question, but I think a lot of people get confused. They think of inflammatory bowel disease as just kind of A or B. It's either Crohn's disease or ulcerative colitis, and that's very specific things, but we actually know that there is at least over 100 types, and that confuses people. Can you explain exactly what that means?
So, I generally think of Crohn's disease and ulcerative colitis as a spectrum, and that patients are somewhere on that spectrum, and there are different manifestations. There are some patients who might have inflammation of the bile ducts, or PSC, others who tend to have a lot of strictures or a lot of fistulas and form abscesses, and some who just have straightforward run-of-the-mill inflammation. The location of disease has a big effect on people's symptoms, and somebody with a lot of rectal activity will have a lot more urgency and incontinence. Somebody with upper tract disease is more likely to have problems with malabsorption. So I try to look at each case as unique and try by analogy to say, what treatments have worked for patients like this in the past. If a patient happens to have family members who also have IBD, sometimes I'll ask, what has your brother, sister, uncle tried, and what worked for them and what didn't work for them, on the assumption that they may have a pretty similar genetic background. So if I meet somebody who says, yeah, I have Crohn's, I just got diagnosed, my uncle, who had really bad Crohn's disease and 5 surgeries, went on Remicade 2 years ago and is now doing fabulously, and say, well, maybe we should start with that. That's actually pretty useful. The other interesting thing about that is if I meet a patient who doesn't know anybody with IBD, who doesn't have any family members with IBD, but is really sick, and I'll say, wow, you really would benefit from a combination of an anti-TNF and azathioprine. A lot of patients who've never heard this before are really terrified about the idea of 2 medications. And even if I explain it, we have clinical trials to show this is the best combination we've got today. They'll be really reluctant and terrified. Whereas if I have a patient who's had a family member who's seen the potential complications, the abscesses, the surgeries, they'll be like, sign me up. What's the best thing you got? What can you do to keep me from having surgery? Get me on it. And it's really interesting to see the difference between somebody who has that deep family knowledge of what IBD can be like. They have a very different view of the medications.
I have to tell you from my own experience that I was terrified to put my son on Remicade, and then on top of it, when Remicade alone didn't work, combine it with methotrexate. I thank God that that was the strong suggestion from his IBD doctors, his GIs, and that I went along with it because it's now what has put him into remission. I can say from being on that side, Doc, that you were talking about with people who have no history of the disease in their family, didn't even know anybody with IBD. That it is scary when you hear these medications, what not only what they can do, but what are some of the side effects from this stuff. And especially when you're talking about, at the time, Dominic was only 7. So what does this mean long term for him? Am I making a decision to try to help him now, but could also be leading to a problem for him later on in life? So there's a lot that you, as a caretaker and as somebody who has to make the decisions for him, there's a lot that goes through the thought process of what is the best thing to do here.
And it's hard when you don't know the potential consequences. If you don't really know that not controlling inflammation now may lead to a surgery 5 years from now, multiple surgeries, TPN, not knowing that spectrum is really hard to know the short-term decision versus the long-term consequences. And that's where going to somebody who really knows IBD and has done this a lot, they appreciate the long-term. Because a lot of times you're really seeing the next 6 months. And it's hard to understand what are the implications for the next 10, 20 years.
Yeah. Getting back to where Sara asks about, over the, that there's 100 types of IBDs and as a spectrum. One of our viewers, Carly Carter, said, I have a severe case of microscopic colitis. I got to tell you, Doc, prior to her telling me this, I didn't even know that microscopic colitis was part of the IBD family. Her question is, why don't you ever hear MC being discussed that much? And can you talk a little bit more about MC?
So 2 reasons. It's less common, and most microscopic colitis is relatively easily treated. Most MC is treated with a little bit of Azicol, a little bit of Pepto-Bismol, maybe some Anacort, and people get remarkably better and do fine. The hard part is there's probably 10 or 20% of microscopic colitis that's really difficult to treat. It doesn't respond to any of those therapies, and suddenly you end up in the realm of the kinds of treatments you use for Crohn's or severe UC. You're starting to use things like azathioprine or Remicade or Humira, and those absolutely help in refractory microscopic colitis, but it's kind of unusual to get there. And to be honest, there aren't a lot of great studies. And there are probably about 15, 20 people in the world who really focus their research on microscopic colitis. There's Daryl Party at Mayo, and Dr. Munch in Sweden, and Eugene Yen at Northwest Lakeshore are the 3 that I know. It's really not that many because it's just not that common. But if you really go out and look for it, and these folks say, I'm a microscopic colitis guy, they have cohorts of 100 to 500 patients who go to them because nothing else has worked. And they need these guys who do this every day.
With microscopic colitis, it's pretty much an inflammatory thing, but do you see bleeding and ulceration and stuff like that in those patients?
That's the weird part about it. You have a lot of inflammation at a microscopic level, but if you look through a scope, it looks totally normal. No ulcers, no bleeding, but these people have enormous amounts of diarrhea. It's disabling because they can't go out. They might have 30 to 50 bowel movements a day.
Wow.
Is it considered a functional bowel disorder or no?
No, it's clearly inflammatory. Yeah.
Okay.
Unfortunately, most people respond to fairly straightforward first-line therapies, but the people who don't really need help.
Yeah. Sure, it's probably not very well understood by most doctors.
Not terribly.
Yeah.
And microscopic colitis comes in 2 subtypes, the lymphocytic, where there are a lot of white blood cells, and a collagenous colitis, where there's a band of collagen that affects water absorption. We don't really understand why they're different and how they're different, but it's pretty remarkable under a microscope, but that doesn't necessarily help us understand better how to treat these.
Right.
Another question from the audience, Veganostomy X, is can you give us your thoughts on the GEM project?
So the GEM project is something that was originated in Canada. The idea is to look at genetics, environment, and microbiome to try to understand what causes Crohn's disease. And the idea is to find 5,000 people who are first-degree relatives of patients with Crohn's, but are younger, and typically ages 5 to 30, who might develop Crohn's in the next 10 years, and get their genetic material, do long surveys about their environmental exposure to animals, antibiotics, you name it, and a sample of their stool microbiome, and follow people for years to see which ones develop Crohn's and which ones don't. And then have all that data and see what predicts who develops Crohn's to really understand what causes Crohn's at a new level. And we've enrolled probably about 25 patients at Michigan. Most of the patients, because it started in Canada, are from Canada, and now it's been expanded to the UK, possibly other countries soon. So I think this is a really great project that the CCFA is behind, as well as the Colitis Foundation of Canada, to try to understand what really causes Crohn's and how these different pieces, genetics, environment, and microbiome, interact.
Do you believe that in order for us to see a cure for this one day that we first need to figure out the cause, or do you believe that we could ever find the cure without knowing the cause?
I think once in a while we'll get lucky, like we got with Remicade, and that's a heck of a story. But most of the time we're going to have to know the causes, and I say causes because there's so many different types of IBD. We will probably find, if we can kind of lump them a little bit, maybe between 10 and 15 categories of causes, and have to have targeted therapies for each one of those to really make a big long-term difference. And ideally, we'd come up with therapies that don't require monoclonal antibodies that people will lose effect with. Hopefully, we'll be able to use small molecules that you can use for the rest of your life.
Great. You see problems in our chat, X's. Since my colectomy, I've not seen much improvement in my fatigue status, although my anemia has been corrected. Is this expected due to the presence of autoantibodies?
Generally, it shouldn't. We usually look for associated other things. Some of it simply can be recovery from surgery. Some of it is just chronic loss of muscle tone and weakness that takes a while to basically rehab back to your normal state. But then we start thinking about, is there some other inflammation going on? Sometimes people with IBD can develop inflammation from arthritis or thyroid inflammation or some other form of autoimmune disease. So we really have to look for inflammation. Speaking about the thyroid, it's important to look for a low thyroid, which often happens in IBD patients. It lowers your energy level. Anemia is also a big factor, and that's one you want to make sure gets better. Iron deficiency itself can affect energy levels. And then beyond that, you have to make sure that there's not something else going on, whether a heart condition, a kidney condition, or something else that could be contributing to fatigue.
Okay. One of our other viewers, James Garman, was wondering, what are some good methods of coping after having 12 inches of ileum and I believe it's ileocecal valve removed? Excess bile is a major issue. Is there medications or drug-free treatments for the issue?
So usually your best bet, and so one of the particular challenges of losing the terminal ileum or having a scarred terminal ileum is that's where we reabsorb bile and recycle it back to the liver, which is really important because normally that is 100% efficient, works great, but if the bile doesn't get reabsorbed and it goes into the colon, it sort of irritates the colon. So the colon has trouble absorbing as much water, actually secretes a bit of water, and you end up with watery diarrhea that's not related to inflammation at all. So generally in that situation, we add a bile acid binder of some sort. A lot of people use cholestyramine, which is generic and cheap but tastes horrible. It usually comes in a horrible powder.
Does anything ever taste good, by the way?
Yeah. Or occasionally we'll use tablets. The common one is called Welchol, which actually has the side effect of lowering your cholesterol. Some insurance gets a little touchy about that because it's more expensive than the cholestyramine, but it's really effective. It won't be perfect. A lot of times people after an ileal resection may go have 5 watery stools a day, and with well call they may go down to 2. They won't have perfectly formed stools, but they'll do a lot better.
Okay. I think Christy Stone was asking earlier, we were talking about Remicade levels, and you were explaining, that there's, you were explaining about the Remicade levels. And one of her questions was, so the levels is to see if you are on the correct dosage. I wonder if, she says, I wonder if you go about dosing biologics differently for children versus adults.
So generally we dose milligrams per kilogram of body size. So for children we definitely give less. So it's fewer milligrams because they weigh less. But the dose per kilogram is the same. We definitely want to have similar blood levels at the trough, and the trough means the period right before the next dose. Generally after you get a dose your level goes very high and then it drifts down over time. We want to make sure that the trough level, as a rough measure, is above 5. And if we can keep it there, you're less likely to form antibodies, less likely to have flares, and more likely to have endoscopic healing. So those are all good things, and we want to make sure that we at least have a good level of the drug in the body. Okay. And if we don't, we may dose a higher dose or move the doses closer together.
There is a maximum dosage that you can do with it, correct?
Well, the maximum that the insurance company will let you dose is probably the maximum.
Okay.
Because the bottom line is whatever the blood level is gives you an idea of how much you're giving. Some people will clear the drug a lot faster and you give more. Usually you'll reach a point with the insurance company where they'll say, hey, we're not going to let you give a kilogram every 4 weeks. Sorry, that's just too much money. Try something else. That's usually the limiting factor, to be honest.
Okay. Adam in our chat asked, I began Remicade in August. Since then, my fatigue has worsened. I've been diagnosed with, and pardon me, I'm going to butcher this, but I've been diagnosed with arthralgia.
Arthralgia, pain in the joint.
Okay. And have suffered greater infections. I still have rectal irritation and bleeding. Does the benefits of Remicade outweigh the risk? Would you recommend a different treatment if the body is not taking well to the drug, but identifies efficiencies in the colon?
So I think there are a lot of things going on worth sorting out. First is there adequate drug being delivered? So checking a trough drug level may be helpful. It may be that he's already developed antibodies against the drug and he's clearing it too fast, so it isn't working very well, which would be unfortunate, but sometimes happens even in the first 8 to 14 weeks on a drug like Remicade. The second thing is if he has antibodies against the drug, he may be developing actually deposits of drug antibody complexes in the joints and developing what sometimes we call drug-induced lupus. That tends to be true in people who have a positive ANA or a positive double-stranded DNA in their bloodstream. If that's the case, you may really have to switch drugs because you're going to have that limiting side effect. The other possibility is that he has joint pain from what's called enteropathic arthritis, where the inflammation from the intestines is going to the joints and causing trouble. Sometimes treating that on its own with something like methotrexate for arthritis or sulfasalazine, which is also really good for arthritis, may make that enough better that the Remicade's more tolerable. So there are a lot of things to sort out there, but definitely number one would be, is there enough drug on board? Two is, are there ANA or anti-double-stranded DNA going on, suggesting he's got a drug-induced lupus? And three, if there's an arthritis that might be caused by the disease itself, you may need to add something like methotrexate or sulfasalazine to treat it.
He followed up with a question, how do you test for antibodies? Is it blood?
Blood test.
Blood test. Okay. Meg, who I think Meg just got here in the chat from her class. She was at a class tonight. She's the front butt YouTuber who just won. Congratulations, Meg, for your WeGo award. Is it common for people who had a colectomy to develop a vitamin D deficiency?
In Michigan, it's common for everybody to develop a vitamin D deficiency, so it's hard to tell. You don't get much sun.
Yeah.
And she's from the sunny state of Florida, too, by the way.
Yeah, so I have to say it's hard to know. I know that about 80% of IBD patients in Michigan have vitamin D deficiency. I've heard that in Florida it's probably in the neighborhood of 40 to 50%. I think it's more common in people with active inflammation, especially inflammation of the small intestine. Offhand, I don't know that colectomy necessarily would, but vitamin D is actually interesting and a little controversial right now because there have been several studies suggesting associations between vitamin D levels and disease activity, and particularly Crohn's disease, showing that people with higher normal vitamin D levels are less likely to have hospitalizations and surgeries. Again, this is an association, so you could say, well, if people are doing well, they're more likely to absorb vitamin D, and it may not be meaningful, it may not be causative. There have been a couple of really small studies, one in Ireland and one in Scandinavia, where they supplemented vitamin D, and patients did a bit better in terms of quality of life and disease activity. So the CCFA is actually sponsoring a pilot study, multi-center, to look at if you supplement vitamin D in IBD patients who have low vitamin D, will it make a difference in their outcomes? So that's just getting underway. Probably first patients enrolled in April.
Great. Mike Porter, who's in the chat, asked an interesting question. In fact, Ryan, I think you asked a similar question to this last year at DDW when we started the IBD Social Circle. Any info on artificial colons or colon transplants? Basically, he wants to become robo-colon.
Yeah. To be honest, there is not a ton of work on colon replacement, in part because the majority of patients without a colon can survive and live full lives. But there is an enormous amount of work in people trying to regrow small intestines. And because once the small intestine, you're really in trouble. You can't absorb enough nutrients to survive, and a lot of those folks need to live on TPN full time. The biggest move right now is taking stem cells, growing them with various growth factors into organoids, and most recently a group transplanted these mini organs or mini guts into mice and showed that they could grow very short, maybe a centimeter long, pieces of small intestine. It's very, very early. It's a very first step, but people have started to think about, could we do more than this? And there was a nice presentation this past weekend at the AGA Tech Summit of folks who are trying to use 3D printing and stem cells to basically 3D print new livers. I think if that technology comes around, we will probably look seriously at trying to 3D print from stem cells, either small intestines or eventually colons, to see if we could actually do that. The challenge then is, can you find a surgeon with enough endurance to hook up all the blood vessels needed to keep a small bowel or a colon alive? That's a lot of blood vessel connections and a lot of really tiny sewing. But the technology is moving fast, and we've done a lot of 3D printing at Michigan. We have a couple of famous cases of 3D printing tracheas to replace in patients. And to be honest, trachea is a little bit easy because they don't have blood supplies, but it's a starting point. We have successfully 3D printed organs and put them into people, and they've done well.
Given that I'm sorry, Ryan, did you want to say something, or?
No, it's very interesting.
Yeah, very, very. I mean, given that I'm the resident geek on this panel, what are some of the technologies that are not quite there yet, but that you see on the horizon that are really going to make a big impact in IBD?
I think a lot more targeted small molecules. So if you start a therapy and it works, you'll be able to stay on it forever, or even go off it and be able to go back on it. I think that's going to be a big, big deal. Right now, we're just fighting, trying to keep one biologic going and then trying to catch the loss of response and starting the next one. So that's going to be big. It's likely that some form of 3D printing organs is going to come and going to be a big deal. It may be a lot longer than we'd like. I wouldn't be shocked if it's 10 to 20 years, particularly because the gut is an active immune organ. I think we'll see a lot of progress on easy organs in the next 5 to 10 years. The intestines may come later because they're hard, and somebody's got to figure out the blood supply problem. Once you get it together, how the heck are you going to install this? 20 feet of small intestine with, a new blood vessel every 2 inches. That's a lot of blood vessels, and we have to come up with a way to make our surgeons a lot more efficient to make that work.
I can do it.
Yeah,
I can help.
Eventually,
You guys are
it'll be
lazy.
interesting to see if antisense technology pays off. This is a way that uses nucleic acids to target particular genes and turn them off. That's the idea behind Mongersen. It's supposedly turning off SMAD7, which is involved in the TGF-beta pathway, which regulates inflammation. The challenge with that is delivering it to the intestine, getting into the cells, and keeping it working. But that would be an incredibly specific way to change disease.
Christy Stone just had a really interesting thought, and the chat's flying by, so I'm trying to see it. She goes, it's about, I wonder if that's, or no, I'm sorry. And if you grew a bowel with your own DNA, will your disease come back as it, is part of?
Yeah, that's a real good question. So what little we know is mostly from bone marrow transplants. So probably in the late 70s, people noticed that folks with IBD who got bone marrow transplants for, say, leukemia, their IBD would be much better for a while. Unfortunately, most of the time it would come back 2 to 4 years later if it's with your own cells, with your own immune system. And so there's been debate in the bone marrow transplant community, if you have somebody with Crohn's, are you better off having a less good match so that you don't have the same immune system? Most of the bone marrow transplants for Crohn's today are with autologous, or with your own bone marrow cells, which resets your immune system, which is great, but you have fundamentally the same issues, and the same stimuli may eventually trigger the Crohn's again. The one really interesting thing from one of the Northwestern University papers on this was that people who smoked after bone marrow transplant were much more likely to get their Crohn's back sooner. So that's the one factor we know about.
Dana Gentry Smith is in our chat, and she says, my son and husband both have Crohn's disease. My husband started having symptoms while in the Navy. He had surgery and was retired. They did 7 stricturoplasties. He thinks that this has developed so much scar tissue and is a problem at this point. Not sure how to ask my question, but what options does he have? He is a reluctant patient.
So I guess one thing to sort out is there active inflammation? And if there is, there are many, many treatments for that. We have all kinds of good therapies for inflammation. If it's fundamentally scar tissue or fibrosis, right now we don't have a lot of proven therapies in Crohn's disease. There's a ton of research going on in that. My lab works on this, and particularly on the scarring in Crohn's disease. There are currently 2 treatments for fibrosis approved in the U.S., both for pulmonary fibrosis. So there's a lot may eventually have a big impact on performing scar tissue in Crohn's, of surgery in Crohn's disease.
Okay. So Allison in our chat asks, fecal transplants with the increase of obesity and diabetes, talking to the GIs of reasoning, but better for UC in a course of C. diff. Not really sure what her question is there.
So there's a lot going on in fecal transplant. Unfortunately, it's a very mixed bag. It's incredibly effective for C. diff, in the range of 90 to 95% effective. Unfortunately, it's also been hyped for lots of other things, from obesity to autism to IBD. At this point, for other indications, it's pretty disappointing. There was a recent study looking at fecal transplant for obesity where they took stool from skinny people and put it into overweight people. They didn't see any change in weight. They've looked at it in ulcerative colitis and Crohn's, and to be honest, it's been fairly disappointing. Every once in a while, they see some clinical benefit, but not much change in endoscopy or biopsies or objective markers like CRP. So at this point, I think folks, at least in the IBD field, are pretty disappointed in it and a little bit taken aback by some of the adverse events we've seen. For example, in the New England Journal about 4 months ago, they reported a case of a father in Boston who decided he really was afraid of the potential risks of immunosuppression and biologics and decided to administer himself a fecal transplant from his toddler, and unfortunately ended up with multibacterial blood infection. So stool transplant is somewhat natural. Stool is certainly natural, but it can be pretty dangerous, especially in patients who have active ulceration and basically have holes that connect their colon to their bloodstream. And effectively, you can put bacteria into your bloodstream with stool.
Josh Higgins in our chat asked, going back to about Pentasa, did the FDA ever approve Pentasa and fellow drugs for Crohn's in the past?
FDA only approved it for ulcerative colitis.
Ah, interesting.
Like Pentasa, that is?
Mm-hmm.
I thought that was diagnosed in the small intestine, or broken down in the small intestine.
And that was the hope of the company when they created it, was to prove that it was effective in Crohn's. And it's actually a horrendous and somewhat scary story. So the company involved, which I will not name, performed 2 studies in Crohn's, and neither one worked. So they buried the data and did 2 more studies. One of those barely was significant. They published that one and buried the other 3. And, tried to get it through. The FDA requires them to disclose all of their studies, which they did, and so the FDA didn't approve it. But because that published study that made it look good was out there, docs started using it because they didn't have a lot of choices at that time. And huge credit has to go to Stephen Hanauer, who is an IBD physician at Northwestern, who actually went to the trouble of filing a Freedom of Information Act with the federal government, forcing the release of the other 3 studies. And he published those on his own as a meta-analysis to show people that, yes, this really didn't work. Because the company, unfortunately, was trying to hide it.
Wow. I didn't know that. It's interesting.
Phoebe, get out of the limelight.
Phoebe!
Doc, Ryan, welcome back, Ryan, by the way. Ryan touched on the fact that you're very active on Twitter and on social media. And like he said, we really appreciate that. But why, and again, I'm not asking you to speak for other doctors, but why do you think other doctors, other GIs, have such an issue with social media? Are they afraid of social media? Is their legal concerns? Why is it that you are a rare species when it comes to social media and medical doctors?
I think there are a couple things. There are definitely legal and liability issues. You have to be pretty careful about offering very specific medical advice, and you could say, you could be sued for offering medical advice that led to a bad outcome, and it's a real issue. There's also an issue that you have to have pretty thick skin. I know a number of docs who've dipped a toe into social media and gotten attacked pretty viciously. By the community.
That's rough.
I think One, I think you have to, I personally try to stay away from talking about complementary and alternative medicine because it brings out very angry people, and I just stay away from it. But even then, I was on a Facebook chat with a CCFA and had just kind of random nasty comments thrown at me for no good reason.
I shut those down. I saw them.
Yeah, pretty.
Like, shut your face.
It's unpleasant. So you have to have a thick skin, and I think that's a big part of it. I think a lot of people, a lot of docs feel like, this is an extra effort. I'll put myself out there, and if they get attacked, a lot of times they'll just walk away. I have a particular interest in getting feedback from patients because I got involved in a project that was sort of inspired by the FDA, believe it or not, when a few years ago they decided that the way we decide whether drugs work for IBD or not doesn't have enough patient input. And so I got involved in developing what are called patient-reported outcomes measures. And we actually started by going to focus groups of patients around the country and asking them what the most important symptoms were to them in their Crohn's disease and ulcerative colitis experience. And we developed an instrument that hopefully in the next year will be qualified for use in trials in IBD for deciding whether drugs work. And so the basis will not just be does it control inflammation, but does it actually make patients feel better. And one of the really neat things about that, and I'm going to present this at the FDA at the end of the month, is that for Crohn's disease, we looked at the top symptoms that patients really cared about. 1 and 2 were abdominal pain and stool frequency, but number 3 was fatigue. And that had never been included in any measure of whether a Crohn's disease drug worked or not. And so we put that in our instrument, and hopefully in all future clinical trials, that will be part of deciding whether the drug really works. Does it actually change the experience of fatigue as well as inflammation?
Do you think that patients get enough, how do I want to put this? Do you think that patient input is a concern in the medical community? Is something that is looked for when seeking whether or not anything that they're doing is working well? Is it strictly just the science, or does how the patient thinks and feels matters as much as well?
And I think that comes with experience. I don't necessarily think that's taught terribly well in medical school or residency. You're taught, here's the evidence. If the patient has this disease, the best treatment is X. I'll certainly tell patients, based on the average patient, the best treatment is X. But that's not necessarily the best treatment for that patient. If I prescribe azathioprine for a patient, and they go home and they read about lymphoma and they say, holy cow, I'm sure I'm going to get lymphoma, I'll never take this medicine, and they show up 6 months later hospitalized with an abscess, I haven't done that patient any good. And so it's really important to talk to the patient and try to understand where they're coming from, what their priorities are, and what is the right treatment for them. And it takes a lot of work to really understand for a given patient. I was talking to a patient today who was on a therapy that was pretty good, but not great, had developed strictures, and had to choose, the by-the-book treatment would be say, hey, let's step up to a biologic. He looked at it, he said, I could, but I'd rather have surgery. And I said, well, that's a pretty unusual decision. Most people are terrified of surgery. But I talked to him for a good long while about why he felt that way and, risks and benefits. And he really seemed to understand the decision. And he's going to go see one of our surgeons and say, look, if I can do a laparoscopic surgery, I'd be happier than going on a biologic. There's no guarantee he won't end up on a biologic 10 years from now. But this is the decision he wants to make that's the right decision for him right now. And that really comes with experience and making the mistakes. I've certainly told patients, hey, the best treatment for you is X. You need to take X. Go take it. And come back 6 months later and say, wow, that was a big mistake because that patient really wasn't ready. Whether they had some reason they didn't want to take it, they couldn't take it, they couldn't afford it. Maybe they didn't want to tell me, their insurance wouldn't cover it. But because I didn't dig enough, especially earlier in my career, I didn't help that patient very much.
You see problems in the chat wrote, have you found that patients who are well read from sources on the internet to be harder or easier to treat?
That's a good question.
Yeah, it's sometimes easier because they know a lot and they have a better handle on the data. Unfortunately, though, sometimes they don't have a good sense of what's good data and what's bad data. And nothing on the internet ever dies. And I think the best example in this case is the whole naltrexone story. So there was a study probably 10 years ago now from a doc at Penn State who showed that naltrexone seemed to work in mouse models of IBD. It was encouraging and worth doing further studies. They did an uncontrolled trial in patients, in about 20 patients, and the patients said they felt better. It was very encouraging. And then they got funding for a prospective randomized clinical trial, which is really the way to test it. That didn't work. When they measured objective inflammation, didn't make a difference. The problem is there's all this data out there all over the internet about the mouse studies and the original uncontrolled study, and no one's going to say, hey, by the way, in the prospective trial it didn't work. So I have a lot of patients who say, I read this about naltrexone, it sounds amazing. And they don't know the difference between a study of 20 patients who took a drug versus a randomized clinical trial. And there's no way they would. I mean, they haven't gotten a master's in clinical research, but it's hard to really sort out what's real on the internet and what's looks legit and was legit for its time, but now we know better. And it can be hard untangling that for people.
That kind of takes me into another question that I had, and try to follow my hypothetical here for a second. The hypothetical is I was diagnosed with Crohn's at the age of 15. I'm now 35. I've been living with this disease for 20 years. I've had the gamut of surgeries, of strictures, of fistulas. I'm a severe case, so I've been through it all. I'm in an excessive amount of pain, and I go into the emergency room, and because I'm so well informed, because I've been on so many drugs, I know what medications work for me, what medications don't work for me, and what it is that I can do to not only save the doctors and nurses time, but also that if they were to say, all right, we're going to give you some Toradol for the pain, but I know that Toradol doesn't work for me whatsoever, but maybe either Percocet or Dilaudid does. And instead of them putting that into me, Toradol, when I know it's not going to work, the minute I say to them, that doesn't really work, why don't we try Dilaudid, at 1 milligram or 2 milligram? Immediately, all these red flags go off, and they think that you're a drug seeker and that you're just there to get high or something like that. When someone is chronically ill, and they're severely chronically ill, they know what's best for them. They're informed, they're smart about what it is that works and doesn't work for them. Why does that all of a sudden send off all these red flags to doctors and nurses? And what can be done to help the chronically ill not get labeled as drug seekers when they know what works for them?
Mm-hmm. Well, the first thing you have to do is get rid of the other 90% who are drug seekers, because they ruin it for everybody. Because if you went into an emergency room and said, I know what I need Tylenol. Tylenol works great for me. They'd be like, great, fabulous, here you go. Or if you said, look, I really need morphine. Morphine works great for me. When you start using the D words, and I include Demerol as well as Dilaudid, they're narcotics that work well but have a euphoric effect. That sets off a lot of alarms, because for every IBD patient who comes into an emergency room with pain, they probably see 20 people with chronic back pain, neck pain, whatever, who want to get Dilaudid, who want to get Percocet. And, docs get jaded. They've seen it a million times. And if you can get by with morphine, to be honest, you're less likely to get labeled. And it's a challenge. And the other issue, particularly for people with colonic disease, you know that you're not necessarily treating the disease, you're treating a symptom. And, there's a place for that, but there's also potential harms with narcotics and IBD. It's been well established that patients who use narcotics for IBD are more likely to have infections, to have strictures, to need surgeries, and to die. The death rate is about doubled in patients who use narcotics. So there are reasons to be hesitant to use narcotics in IBD. And, I think it really comes down to, have you established a relationship with the doc? And it's really hard to do in an emergency room. That's the fundamental problem, is this doc doesn't know you. And to some extent, they're generalizing and lumping you in the last 9 people who came in asking for Percocet or Dilaudid.
Is there a way, and I'm thinking out loud here and just hoping that, is there a way that a nurse or a doctor can take the time to decide or to figure out whether or not this is somebody who's strung out looking for, a euphoric high, as you were saying, or somebody who is, chronically ill who is well informed? Can we get well informed, license cards or something to present when we walk in? I mean,
one thing that's actually done in Michigan and an increasing number of states is the state actually has a narcotic prescription tracking mechanism that you can look up a patient. And if you look up a patient in the state of Michigan and they've gotten narcotics from 8 different doctors, from 9 different pharmacies in the past month, then all kinds of red flags go off. If, on the other hand, you've gotten narcotics from 1 doctor, once every 60 days, you come across as a lot more legitimate patient. And, that's something that docs are starting to do more of, because they don't want to get burned by the guy who's asking for the 7th narcotic prescription in 3 weeks, and to be honest, maybe going out and selling them. And that happens a lot, unfortunately.
Yeah.
OxyContin has huge street value.
It does. I mean, and I don't pretend to believe that there is an easy fix to this, but there's got to be a way, or a better way than what we've currently thought up, in order to help the people who are chronically ill and chronically in pain, and those that are, seeking a high. And it's just sad. It's obvious when, and somebody who, has a long list of problems that they've occurred from IBD, and yet get lumped in with all the drug seekers and stuff like that.
It's a huge problem, and it's a challenge, especially in IBD, because there's no question, for the average patient with IBD, narcotics are going to do more harm than good. And so to be able to filter out which patients, because of scar tissue, and we don't have a good treatment for scar tissue, that really is the only option. If we could come up with non-narcotic pain relief, whether it's a TENS unit or something else, that would be great, because that doesn't carry the same stigma. And it's a challenge. And the emergency room is probably not the best place to try to fight that fight.
Yeah. I think it goes also back to the point of some doctors, some GIs can become very dismissive as well. So of concerns and problems that patients are having. I guess there's just really no. I see this a lot in IBD patients, where they're frustrated. They feel like they have to dumb themselves down when they go to seek help, because if they walk in there well informed, they're automatically labeled right away. And it just makes it a little bit more difficult to get the kind of care that that you need.
Well, I do think there's a certain level of frustration that when a patient shows up with straightforward inflammation, we can be very successful. Docs love that. So bring on the inflammation, I can treat that. Right now, we're terrible at treating scar tissue, and that's just, hard on everybody, the patient, the doc, to say, fundamentally, I don't have a good treatment for what you have.
Mm-hmm.
And that's really hard for both sides.
Yeah, it is. It is. All right, so we're going to get ready to wrap it up in a minute. If I'll give the chat one last minute to throw any questions that they have in there before we wrap it up. Panelists, do you have any additional questions or things that you want to talk about?
I do.
Ryan, go.
Okay. Dr. Higgins, I'm trying to sell my body to science. And as you know, I live about 45 minutes from Ann Arbor.
You ain't going to get very much for it, but go ahead.
I know. But is there any, I'm just joking, by the way, but is there any study that, I kind of don't qualify because I don't have a colon, but is there anything going on at the University of Michigan that, I could come up and say, hey, here's my body, study it, and I want to try to help?
For most people, and this is true at Michigan and a lot of centers, is there's some form of biobanking or long-term study where they follow people over time to see what medications work, what genetic factors work. And on a multinational level, the GEM study is a great example of that. That, most therapeutic trials require you to be actively sick and looking for a new therapy. But something like the GEM trial, basically, you just have to have Crohn's and a first-degree relative, and you're good to go. And those kinds of studies can really make a difference. So usually it's a biobank or a data bank or something like GEM, which is basically an international version. And the CCFA, through what they're currently calling IBD Partners, is going to have a national rollout that hopefully will be at many centers throughout the U.S. that people can contribute to. Some of that will be blood, genetics, and answering surveys about their meds and how they're doing.
Victoria Marie in the chat has a really good question. How can we increase the focus on the human side of IBD, such as providing better support for anxiety, depression, career advice, learning how to process and accept IBD? We talked about once before that the mental health side of IBD is rarely talked about in a doctor's office. How can patients get better support for that, especially newly diagnosed who don't realize what they're about ready to face?
Some of it is each patient has their own process, and as I said earlier, sometimes they're very sick, but they're not psychologically ready for the next step or the next med. It's a common problem that stress is a big issue, and processing the diagnosis and what it means is such a big issue that a lot of centers are really moving to hiring specialists who do this. We have Megan Reel at our center who does stress reduction and behavioral health, and has been a huge benefit for our patients. And I know Pittsburgh does it. I know Northwestern has folks. So I think that's something that's slowly rolling out across IBD centers. And I've found it in my patients just to be enormously beneficial. But it's something that's really just starting to take off in the field.
Yeah. I did not realize, when Dom was going through the stretch of about 3 years where his IBD was at its worst, the mental side impacted me, and I was just his caregiver so greatly that it put me into a depression, and what I really believe has that I have some PTSD with it. Back at Thanksgiving, he showed a little bit of symptoms again, and immediately that was like a whirlwind for me. And it's just it's amazing how this disease can just mentally wreak havoc on your psyche. And there's really not enough attention being paid to that, and I'm glad to hear that it's coming along, but there really needs to be more.
Mm-hmm. And, you know, we have a lot of information from other fields that the things that are most likely to induce PTSD are things that are unpredictable. You don't know when they're going to hit. You don't know how bad they're going to be. You worry about warning signs all the time. A classic example was night bombers in World War II who flew without radio, without instruments, in the dark, and could be shot down at any time by anti-aircraft. Actually had the highest suicide rate ever recorded. And if you step back and think about IBD, not knowing when the next flare is going to happen, how bad it's going to be, how it's going to disrupt your life, it has that same kind of unpredictability that can really bring on a PTSD kind of phenomenon that you're always kind of anxious and worried, when is it going to happen? And it can be enormously disruptive, both to patients and caregivers. And for a lot of times, patients, it can reduce them to the point that I just can't plan anything. And they'll give up on goals, whether it's going to finishing high school, going to college, getting married, having kids, and saying, I just can't do that because I don't know what's going to happen tomorrow or the next day. And it can be very hard, even when a patient gets better, if you find the right therapy and the right dose, to say, okay, now you're better. Let's step back and say, okay, you know, what are your goals? What have you given up in this process, and what can you get back in your life? You know, now that you're better, maybe you can go to college, maybe you can do that graduate degree. And really kind of getting people to get past that, which is very hard, to say, yeah, you know, I've got my life back, and now I need to take advantage of it.
Yeah.
Is this something that you specifically talk to your patients about, like their goals and everything, or is it just something that you think that they kind of need to talk to someone about? Because I know that, you know, you guys have limited time and your focus
Sure.
is really the therapy part of it. So I'm just wondering how you go about it.
Yeah, and it's sort of you know, seeing a patient as a continuum. A lot of times when I first see them and they're very sick, you know, I'm trying to sort out, what do I need to do for inflammation? Do they need surgery? But a lot of times, 6 months, a year, 2 years later, we're at the point where I'm saying, okay, great. You know, we're just doing health maintenance now, your vaccinations, checking all the dots. You're doing great. You know, you've gained weight, you're putting on muscle. What are you doing in your spare time? What's your career like? Is it what you wanted when you were 17? And sometimes people go, wow, you know, not really, actually. But is it okay? Can I do that now? And just kind of starting that process and just kicking the gears a little bit, I think patients will start thinking about that on their own, but they just need a little bit of a push. Say, wow, you know, I've had a lot of patients say, you know, I'm going to go back to college. I'm going to do that graduate degree or whatever that I always thought I wanted to do. Or maybe they'll say, you know, I always thought I was going to do this, but, you know, having been through what I went through, you know, I'm going to go to graduate school in psychology because now I completely understand stress management in a completely different way.
Right. Right. Yeah.
So I'm going to go ahead. I'm sorry.
No, I was just to say, I know the first thing is obviously to get the physical issues under control in order to kind of be able to get in the mindset of, I have some sustained health, I can maybe reach for goals that I haven't before, but that's obviously tough to do. But
yeah, and then, you know, to be honest, I have an enormous amount of help having Dr. Reel down the hall. So, you know, I can say, you know, I'm an amateur at this, but I know a really good psychologist who's just down the hall who can help you out and help you process this over multiple visits and kind of ruminate through what you want to do and where you want to be and, you know, where you want to go from here.
Yeah, no, I'm sure that's enormously helpful for your patients.
I'm going to take this is the last question from the chat, and then we're going to start wrapping it up. Adam asks, I'm very interested in the role of nutrition, and I'm sorry, just scroll past me, and its potential activation, deactivation, and malfunctioning of genes. Is there research in that?
Surprisingly little, partly because it's really hard to control people's diet. People aren't mice, they don't live in cages. And because there's so many other factors, from the microbiome to the genetics. We do have good data, not huge data, but good data, that particularly for people with bloating, distension, and pain with Crohn's disease, they can really benefit from a low FODMAP diet. which reduces the simple sugars that bacteria get to generate gas and cause distension. That we have nutritionists who we use to counsel on low FODMAP diet all the time. There is more research going on looking at how diet affects the microbiome and how that may affect IBD. So far, no diet has been shown to reduce inflammation, but that's sort of the hope. I worry, though, that it can be very difficult because of the so many different subtypes of IBD that you might find a diet that works really well for one patient that might not work well for another patient. And so generally, I'll listen to patients who say, wow, you know, such and such a food, cauliflower, boy, that really doesn't agree with me. That may be totally true for that patient. It may be less true for another patient. The other thing that may be important is that in Japan, they have some data, and they do this a lot, that completely pre-digested liquid diets, enteral nutrition, may be helpful in reducing the stimulation to the immune system of the gut. The challenge is that stuff tastes absolutely horrendous. And to do it in Japan, they basically train people to put down an NG tube on themselves 3 times a day and use a funnel to pour the stuff down. Most people can't do that.
I'm sorry to interrupt, but that was actually the first treatment option after Dominic was diagnosed. And again, he was 3.5 at the time, but it was NG tube feedings for the first year and a half.
Yeah.
Is that just because of the way the food is broken down, because it's still going through your system?
The theory is by having it broken down to individual amino acids and lipids, it's less antigenic and less likely to stimulate the immune system. The data is okay, and there's much better data in kids than in adults. I have occasionally met adults who are absolutely gung-ho about it and do it, you know, liquid meals 20 times a week. But you know, everybody will tell you it tastes pretty dreadful, and most people can't do it long term.
All right. Well, panelists, do you have anything else that you want to ask of Dr. Higgins before we go?
I just have a kind of uplifting way to end it, if we can.
Of course, as always.
I just wanted to ask, like, what is the, maybe if it's an instant or overall, but what is the most rewarding thing to you about being a GI doctor?
I think the biggest thing for me is seeing somebody who's just horrendously sick, whether they've lost a ton of weight or they have 20 strictures, and they're just terrified. They don't know what the options are. They haven't had the help they've needed. And to, over time, over a year or two, get them to the point that they're a lot healthier, they feel better, they add muscle, they're stronger. For young women, their hair looks better. They love that. If they go from no nutrition to like fabulously healthy hair. And then to be able to say, wow, I feel better, I look better. I feel better than I thought I ever could. I didn't realize how sick I was and how badly I felt until now. And then to say, you know, I can do all kinds of things that I couldn't do a year and a half ago. I have so many more options now that I never had. And patients really, truly from the heart, thank you, in a way that doesn't happen every day.
Yeah, that's really cool. It must feel really good to help people like that.
Well, Doc, I don't know if you can see the chat, but those thank yous are right now rolling in for you all throughout the chat. The chat is, the people inside the chat are extremely grateful for you being here, as well as, you know, all of us here on the panel are really, you're taking time out of your night where you're not on the clock right now, we're not your patients, and yet you're sitting here answering all these questions for us, which is just, you know, absolutely amazing. We thank you so much for doing this with us.
Thank you.
No, thank you.
Yeah, thank you.
All right.
So as we normally do as we close out the show, I'm just going to give everybody, I'll start actually with you, Dr. Higgins. Can you just let everybody know where, if they want to follow you, if they want to see the information that you're putting out, where they can find you on social media and how they can, you know, just follow what you're doing?
So on YouTube, we have a lot of patient education videos, including some new ones on measuring inflammation, like CRP at IBD School on YouTube. On Facebook, we're the Michigan IBD team. And on Twitter, it's at IBD Doctor.
Great, thank you. And I will say that the IBD, everybody should go to YouTube and just do a search for the IBD schools, because those videos are just some of the best videos I've ever seen on explaining IBD in a way that anybody at all, whether you're an informed patient, a newly diagnosed patient, a caregiver, or just somebody who wants to know more about IBD, can, you know, learn about that stuff. And you guys have mastered how to put that information out in such a great way, and thank you for doing those.
I'm wondering what Marisa has on her fingers right now.
I have an adorable little puppy, Phoebe.
Licking something really tasty.
Yeah, my hand, apparently.
Yeah.
That is a 4-year-old dog that never grew out of her puppiness, and is just one great big love.
Yeah, she really is.
So, Sarah, I'll start with you. Why don't you let everybody know where they can find you as well?
Yeah. It's a good night.
No idea where to find you, Sarah.
If you just type in Inflamed and Untamed into the Google machine, that'll take you to the promised land. That's where you can find me. And again, my name is Sarah, and good night to all of you living in the United States of America, where it's night, and for the rest of you, can't help ya.
Ryan, where can everybody find you?
It's Crohn'sGuy.com. And again, Dr. Higgins, thank you very much.
Thanks.
Yep. Marisa?
First, Dr. Higgins, thank you so much for being on the show. It was wonderful to hear everything you had to say, and I really appreciate your time. You can find me at journalingibd.org. I'm on Journaling IBD on Facebook, Twitter, and Instagram, so pretty simple, just that same word.
Great. And I just want to let everybody know that not only do I appreciate my panelists who give up their time to be here with us, and you, Dr. Higgins, I also want to thank everybody in the chat. You guys obviously also have family and other things that you could be doing, but you come here to listen to us blabber and talk about IBD, and I appreciate everybody who watches this show. Remember, go to cceffect.org. If you want to learn how to subscribe to the IBD roundtables on YouTube. You can also subscribe on iTunes or any other favorite podcast catcher that you want. And we'll be back next month for another exciting edition of the IBD roundtable discussion. Thanks, guys. Good night.
Bye.
Night.